Thank you, everyone. So my name is Cassandra Farber. I'm a third-year medical student at the Penn State College of Medicine. And like we said, I'll present on ICD-10 Z Codes and social determinants of health and emergency department encounters for salpingitis and oophoritis. And I just wanted to give a special thank you to the other students and Dr. Marco that worked on this project with me, so Priya, Gavin, and Hayes as well. All right, so this study did not meet the definition of human subject research, and therefore IRB approval was not required. And the authors received no specific funding, and we have no acknowledgements to disclose. I'm going to start off by defining some of the important terms related to this study. So social determinants of health, or SDOH, are conditions in which individuals' access to money, power, and resources influences health equity. Salpingitis and oophoritis are infections of the fallopian tubes and ovaries, respectively, which fall under the umbrella term of pelvic inflammatory disease, or PID. These are serious gynecologic conditions that can lead to lasting reproductive harm, including chronic pelvic pain, infertility, and increased risk of ectopic pregnancy. ICD-10 Z Codes are a standardized system for classifying and coding medical diagnoses and procedures, facilitating healthcare billing, disease tracking, research, public health surveillance, statistical analysis, and clinical documentation. The Z codes, as shown in this table, are specifically related to social determinants of health and include things such as problems related to education and literacy, employment, finances, and social drivers such as lack of housing, amongst others. So why do we choose to look into salpingitis and oophoritis in the ED? Well, many patients with salpingitis and oophoritis initially present to the ED with symptoms such as fevers, irregular bleeding, extreme abdominal pain and cramping, nausea, vomiting, and dizziness, to name a few. This is particularly true for those with limited access to regular reproductive health care in the primary care setting, and thus relying on emergency departments for the majority of their care. Although salpingitis and oophoritis reside under the term of pelvic inflammatory disease, sorry about that. We chose to focus on the former, as these are more likely to require complex interventions such as surgery rather than being treated with simple antibiotics. So our study objectives were as follows. Oops, sorry, I keep skipping forward. To characterize the demographic and clinical profile of patients with documented Z codes presenting to the ED with salpingitis and oophoritis. Once defined, we explored their healthcare management and utilization patterns. This was all in an effort to align with national priorities to improve SDOH infrastructure and support the broader movement towards integrating social context and risk stratification outcome assessment in female populations. Our research included a retrospective propensity-matched cohort study using de-identified electronic health record data from the Trinetics Research Network database. For our study population, we used the World Health Organization of reproductive age females, defined as females age 18 to 49. Within that category, we looked to see who had an ED encounter between January 1st, 2000 and January 1st, 2024, with a diagnosis of salpingitis and oophoritis. 2 cohorts were identified and the data was abstracted on May 29th, 2025. Cohort 1 included patients who had documentation of both salpingitis and oophoritis, as well as at least one or more Z code. Cohort 2 included patients with salpingitis and oophoritis that did not have a documented Z code. The index event took place as the first occurrence of an ED visit associated with salpingitis and oophoritis, and that happened to be during the study period. All patients were required to have at least one subsequent clinical encounter to make sure that they had an active medical record within 5 years of the index event. Study outcomes were analyzed over the 1-year period following the index event, beginning on the day after the index event. We began assessing outcomes starting the day after the initial ED visit to allow sufficient time for diagnostic confirmation and initiation of treatment, thereby minimizing misclassification of outcomes during the initial encounter. For cohort 1, the presence of a Z code on the same day as the initial ED counter was also required. Outcome measures included clinical, procedural, pharmacologic, and psychosocial domains, with a key distinction between outcomes assessed as new events versus those evaluated irrespective of history. So now I'm going to show the results broken up into time increments over this 1-year period, as well as a bird's eye view of the entire 12-month study period. So following propensity score matching, a total of 5,570 patients were included in the analysis, with 2,785 individuals in each cohort. During the first 30 days following the index ED visit, patients with Z code documentation were significantly less likely to undergo surgical intervention, receive analgesic medications such as acetaminophen, opioids, and ibuprofen, as well as ketorolac, as demonstrated by the blue highlight on this table and all subsequent tables. They were also less likely to be diagnosed with peritonitis relative to patients without documented Z codes. Furthermore, patients with documented Z codes were significantly more likely to revisit the ED, require hospital readmission, receive a new diagnosis of anxiety, utilize critical care services, and undergo STI screening compared to patients without any documented Z codes, as demonstrated by the yellow highlight on this table. Between 1 and 6 months following the index visit, patients with documented Z codes exhibited a significantly increased higher likelihood of returning to the ED, being admitted to the hospital, and developing sepsis. This group was also more frequently prescribed analgesic medications. Likewise, this group showed a higher rate of being prescribed antiemetics. Mental and behavioral health diagnoses also occurred at a higher incidence among the SDOH group, including a higher rate of anxiety, depressive episodes, PTSD, follow-up for sterilization, and medical noncompliance. Additionally, patients with documented Z code showed higher frequency of STI screening compared to patients without. In contrast, patients with documented Z codes were less likely to undergo surgical procedures in this time frame compared to patients without. Between 6 months and 1 year following the index event, patients with Z codes continued to exhibit higher rates of ED returns, hospital admissions, sepsis diagnoses, and utilization of critical care services compared to those without. Analgesic use also remained elevated. This cohort also showed a higher likelihood of receiving antiemetic medications, glucocorticoids, and STI screening. Patients with Z codes also remained at a higher risk of experiencing depressive episodes and PTSD compared to those without. Meanwhile, no statistically significant difference was discovered in outcomes observed among patients lacking the Z codes during this time period. Across a full 1 year period, cumulative outcomes further highlighted discrepancies between the cohorts. Patients with Z codes demonstrated a significantly higher likelihood of ED revisits, hospital admissions, and utilization of critical care services compared to patients without. They were also more frequently screened for STIs. Regarding medication use, patients with Z codes were more likely to receive prescriptions for acetaminophen, antiemetics, glucocorticoids, and analgesics. Mental health and behavioral outcomes remained elevated within this population, with significantly increased risk of depressive episodes, PTSD, follow-up for sterilization, and medical noncompliance. Likewise, rates of opioid-related disorders and anxiety were significantly higher compared to patients without Z codes. On the contrary, patients with Z codes were significantly less likely to undergo surgical procedures, be diagnosed with peritonitis, and have an encounter for fertility testing during the same period. Our results showing increased repeat ED visits and hospitalizations, as well as increased requirement for critical care services in patients with documented Z codes, are consistent with prior studies highlighting disparities in healthcare access and usage among socioeconomically disadvantaged groups. Patients facing challenges such as lack of health insurance, unstable housing and transportation, inadequate health literacy, and lower social support have more difficulty maintaining follow-up care, which increases the likelihood of returning to the ED. This increased rate of hospital admission and critical care services among SDOH cohort likely indicates that they're more likely to present to the ED with more severe pathology when compared to those without Z codes, possibly due to disparities related to lack of access to primary care. This lack of access to primary care services in the outpatient setting may also explain the increased prevalence of STI screening done within the ED in patients with documented Z codes. Moreover, our results showed that patients with Z codes were less likely to have an encounter for fertility testing in the following the ED visit, which further illustrates discrepancies in access to specialized care. Another key finding demonstrated that patients with Z codes were less likely to receive surgery. This may indicate financial or insurance-related concerns, which have previously been shown to limit access to surgical care in general. This may also represent a different threshold for hospital admission and timeliness of seeking medical care. Additionally, a physician's implicit bias in treatment of individuals with SDOH may lead them to underestimate the severity of the disease presentation and progression. Another important finding in the study was the difference in pain medication administration between patients with and without recorded Z codes. Patients with Z code documentation were less frequently prescribed pain medications within the first month after their index visit. As such, SDOH factors could be contributing force driving inequitable treatment across patient populations. This finding is consistent with prior studies describing emergency physicians may minimize pain in individuals from marginalized and high-risk populations, contributing to overall disparities in pain management and gynecologic conditions. After 1 month, patients with recorded SDOH codes became more frequently prescribed analgesics than the non-SDOH cohort. Although it is difficult to definitively conclude why that may be the case, this may represent inadequate management of the gynecologic condition within their first index visit, leading to prolonged discomfort and increased morbidity in the SDOH positive population. This study also underscores the unequal burden of newly diagnosed mental health conditions among patients with documented Z codes. Results showed that patients with Z codes were at a higher risk of developing anxiety, depressive episodes, and PTSD the next year following the initial ED visit. This finding once again aligns with previous evidence describing how individuals experiencing SDOH were associated with higher odds of being diagnosed with major depressive disorder and anxiety compared to their non-SDOH counterparts. When it comes to limitations, this study utilized an existing database, which may be subject to inaccurate or missing information. Likewise, our dataset is de-identified and aggregated from multiple healthcare organizations. Therefore, we cannot account for site-specific differences in SDOH coding practices, ED staffing, or local referral networks. With that, Z codes are infrequently and variably captured across the healthcare system, with documentation rates typically as low as 3% in the patient population, leading to potential misclassification, underestimation of the SDOH burden, and selection bias in analysis. This study demonstrates that patients presenting to the emergency departments with salpingitis and oophoritis, as well as a documented Z code, experience significantly different clinical trajectories compared to patients without these documented codes. Overall, this study shows that research analysis based on documented ICD-10 Z codes for SDOH factors mirrors existing literature in illustrating the negative relationship between women's health and social determinants of health. These Z codes provide us with a standardized documentation for important social risk factors and should be given additional consideration in physicians' documentation efforts to accurately record the elements which may contribute to worse outcomes. With improved utilization, Z codes may give physicians additional data points, along with incorporating social context into the management of their patients. Further investigation into the utility of Z codes as a research tool is warranted given their broad applicability and their use in statistical analysis to help elucidate relationships which may be driving worse health outcomes. These are some of my references. Thank you so much.